Hi, thanks everyone. We have no disclosures. So a brief introduction. Chronic lung allograft rejection is a leading cause of late death after lung transplant. The median survival is approximately 5.5 years. We know that GERD is associated with the development of chronic rejection in allograft recipients. The underlying mechanism is thought to be aspiration of gastric contents coming into contact with the transplanted lung and activating host immunity. FEV measurements, the forced expiratory volume, has traditionally been used as a way to quantify the degree of rejection occurring and to assess lung function after lung transplant. Multiple previous studies have shown that Nissen fundoplication is effective in slowing the decline in lung function, thought to be related to controlling the reflux mechanism. We also know that esophageal motility disorders are quite common in these patients. Partial fundoplications have been shown to provide excellent acid control in non-transplant recipients in multiple meta-analyses. So the thought behind our study is, how would our outcomes be affected by performing partial wraps only on allograft recipients with GERD and significant allograft dysfunction? This was a retrospective review of our institutional IRB-approved lung transplant registry. This was over an 11-year period with 53 patients identified. FEV monitoring is done monthly after transplant for the first year, and then depending on clinical progress, it's spaced out to as infrequently as 6 months afterwards. Asymptomatic patients who undergo lung transplant automatically receive an esophagram at 3 months. If any reflux is noted on the esophagram, they're referred for pH probe and manometry. Any symptomatic patients automatically are put in the esophagram, pH probe, and manometry protocol. In terms of our surgical technique, we used a standardized 5-port technique. The hiatus was dissected and any hiatal hernia was reduced. The crus was closed with an endostitch device, and then either a toupee or a door fundoplication was performed based off of preoperative motility. 53 patients were included. 54% of them were female. All of our patients were Caucasian, a function of our geographic location, I think. COPD was the primary diagnosis leading to lung transplantation, followed by idiopathic pulmonary fibrosis. The majority of our patients were not diabetic, and the majority had a BMI within the normal range. Our median time to anti-reflux surgery from lung transplant was approximately 403 days. 24 of our patients had a hiatal hernia on either upper GI or preoperative EGD. The majority of our patients, 48, underwent toupee fundoplication, with 5 patients undergoing door due to severe preoperative dysmotility. 40% overall had some form of dysmotility noted on their manometry studies. Looking into our acid outcomes, our median pre-op Demeester score was 45, and our median post-op was 1.8. All of the patients' FEV values within 90 days of pre-anti-reflux surgery and 2 years post-anti-reflux surgery were pooled into a linear mixed effects model, which functions similarly to a linear regression model. The effect of anti-reflux surgery on the trend of the FEV was evaluated. As is expected, these patients have a slow decline in their lung function after lung transplant, approximately 9 mLs per month in all of our patients. Our model does estimate that there's a slight reversal of this trend by approximately 2 mLs per month at the time of anti-reflux surgery. So in summary of our results, partial fundoplication achieves appropriate reflux control in our case series in terms of their pre- and post-operative Demeester comparisons. Our case series also shows a similar incidence of esophageal dysmotility as previously published research. Our linear effects model does estimate that there's a slow in the decline of lung function with a trend towards significance. And our median time to fundoplication was 403 days. This is notably much longer than some previous published series with more robust results on the FEV values. Moving on to our discussion, as we know that GERD and dysmotility contribute to declining allograft function. Our series of partial fundoplication alone is the first of its kind. We observed a trend towards slowing in the rate of decline of lung function, although this was not statistically significant. It raises the questions, looking at our acid scores pre and post-op, if we did such a good job controlling Demeester scores, why didn't we see a more robust response in terms of lung function? One possibility is our series was underpowered, but I think the more likely thing is that our timing of anti-reflux surgery was a little late. Some research indicates performing this within the first 6 months of transplant had a much stronger effect on long-term lung function. Given the high likelihood of dysmotility in lung transplant recipients, we believe that more investigation should be done on the role of upfront partial fundoplication. We also intend to change our preoperative protocols with earlier referral for esophagram. Thank you.